Welcome to Westmead Private Hospital's virtual GP education program. Today we are joined by neurosurgeon Dr. Jun Kim. Today, Jun will be discussing with us the management and diagnosis of cerebral aneurysms.
So today, I wanted to share with you something briefly on cerebral aneurysms and on the diagnosis and management. And I apologize if it's that is my first time doing this. So I'll try and make it as relevant as possible to everybody here. This is a very, very big topic, and we can get into a lot of complexities and a lot of numbers and things like that. But basically, what I wanted to do was I wanted to talk a little bit about aneurysms in general, and then I wanted to talk about some common situations that as a GP you might encounter. And then importantly, I wanted to share with you a little bit of the perspective from the specialist point of view. And then we'll do some Q&A, and I'd love to get some feedback from you guys or any questions about some of the common situations that you guys run into or you're having trouble with. So as a brief introduction, we all know what aneurysms are, but interestingly, the exact pathophysiology remains unclear. As you know, we have the intima, the media, and the adventitia in a vessel wall, and we know that in a cerebral aneurysm, there's a defect in the intima and more importantly, the media layers, which allow for this berry aneurysm to form. So you can see a diagram here of normal vessel compared to what it's like in a berry aneurysm. And for the purposes of this talk, I want to just talk more about sort of berry aneurysms and not so much dissecting aneurysms, traumatic, there are infectious aneurysms and things, but I'm going to try and focus more on the common things that you might see in your practice. So we know that between 2 and 5% of the population will harbor an unruptured aneurysm, and this is a significant number. And the implication is that I'm sure all of you guys have seen unruptured aneurysms in your practice, and it's one of the more common pathologies that we see incidentally. The rate of subarachnoid hemorrhage remains about 6 to 8 per 100,000. And, with modern day care and intensive, the way that we retrieve patients, the way that we look after these patients in the intensive care unit, the rate of mortality, if you've had a subarachnoid hemorrhage, has gone down from about 40% down to about 25%. But we know that although the mortality goes down, this is associated with, a significant burden of disability, especially in younger patients that have this. So ultimately, when we're managing aneurysms, we're trying to avoid a subarachnoid hemorrhage. And you can see on the CT scan there, is a non-contrast, CT scan, and we can see the blood all around the basal cisterns, thick blood in the sylvian fissure here and here. And we see signs of early hydrocephalus here. And this is classic for an aneurysmal subarachnoid hemorrhage. These patients come in to me, I look at this scan and I think this is a extremely high-grade subarachnoid hemorrhage. The brain looks absolutely full. You worry about hydrocephalus seizures, significant vasospasm, and you worry about a poor neurological recovery. Many cases in elderly patients who have a high-grade subarachnoid hemorrhage, we will just palliate without doing any intervention. And really what happens when an aneurysm ruptures like this, the aneurysm is under tremendous pressure. So imagine the systolic blood pressure pumping from your heart coming through the berry aneurysm defect. And so you get a sudden surge of raised intracranial pressure. And really, if the aneurysm doesn't stop bleeding within the first 1 or 2 heartbeats, the patient will just die. So I want to sort of talk about what might be some of the common presentations as a GP you might see. So the first thing I want to ask you is, which of these scans do you think is the ruptured aneurysm? So I've got 2 scans, and it's kind of a trick question in that actually both of them can be a ruptured aneurysm. So clearly on the left-hand side here, similar to the scan that I showed you a little while ago, you can see that there's thick blood in the basal cisterns. blood in the sylvian fissure, and the basal cisterns here are the arachnoid spaces where you get CSF and where the circle of Willis lies. And that's why you see, more blood here would make me think that this is an anterior cerebral or anterior communicating artery aneurysm. More blood localized along here would make me wonder whether there's a middle cerebral artery aneurysm, and further posterior could be either a basilar aneurysm or something like that. This one is a normal looking CT scan. I don't see any blood here. But the important thing is that the ruptured aneurysm can be CT negative. And it's really important that we pick up a CT negative aneurysm, because these generally are a very good grade aneurysm, as it means good grade meaning good clinical grade. So somebody is headachy, but they've had a ruptured aneurysm, but their GCS is 15. That is somebody that we can fix and we can keep that way, as opposed to somebody who's in a comatose sort of state. And what I want to try and really emphasize is that, and I think that sometimes this is really something that you can actually see in your rooms, that the history is key. And I know that all of you must be inundated with people who have non-specific headaches. And the key thing with the subarachnoid hemorrhage is sudden onset, severe, and people will say that this is the worst headache of my life. And they will say very different from an existing migraine or something that they've had, or other headache syndrome. It will often wake somebody from sleep. Some of the other things, can you imagine if people do Valsalva maneuvers, raise their blood pressure, that sort of thing can cause somebody to have a sudden spike in blood pressure and rupture an aneurysm. So a fairly common time when we see aneurysms rupture can be if somebody gets really heated during an argument with somebody and starts yelling and screaming, and then suddenly has a really bad headache, or they could be on the toilet straining, or it could be during sex. So any kind of thing where they're really straining, Valsalva maneuver, and they have a sudden onset severe headache, you've got to worry about a ruptured aneurysm. The headache will be bad enough that it'll wake somebody from sleep. It can be associated with some vomiting or neck stiffness, photophobia, and a sentinel headache may have occurred a few days prior to seeing you. They might say, look, I had something similar a few days back, which is really bad, but I didn't seek attention. And, it's really important, because there are some people that are super stoic in the community that will just put up with this and not come to you unless it's really severe. And what you don't want to miss it in this state, because if you leave a ruptured aneurysm, then the chance is about 50% that it'll rupture in the next few weeks. And if it re-ruptures, the mortality goes between 80 to 90%. So you really don't want to have a situation of a re-ruptured aneurysm. So a good grade subarachnoid hemorrhage that comes to see a GP is a very possible situation. So, of course, any case like this should be referred to the nearest hospital, and these patients, I'll always give them a CT angiogram and a lumbar puncture. On occasion, you can do an MRI scan, and you can look at the gradient echo and the SWE sequence for any blood products, and those can be quite sensitive too. And we're really testing for red cells, xanthochromia and bilirubin, and we've got ways of working out if they've had a ruptured aneurysm or not. So that's very, very important. The second thing is an incidental finding. And, I think this is probably the most common thing that you all will see, where people have investigations performed for non-specific symptoms. The really common ones seem to be non-specific headaches, dizziness, some sort of memory disturbance, or other incidental finding. And, when you find an aneurysm like this, for a lot of patients, it can cause a lot of anxiety. So we know that there are some studies that looking at patients that have aneurysms that are managed conservatively, that know that they have a brain aneurysm, and this can cause significant anxiety. Up to 25% of these patients can provoke an underlying anxiety disorder, or feel depressed, a bit anxious about the fact that they have an aneurysm. And I'm sure the kind of common questions that they are going to ask you, or that they're going to ask themselves, are, what does this mean? What is my risk of bleeding? Now that they've read on the internet that there's a mortality of 25% if it ruptures, do I need to have it treated? And am I going to die? And I'm sure you have patients that are asking various questions like this, who are doing a lot of Googling, super anxious about it, and understandably so. And so if you do find an incidental aneurysm, the sort of questions that you want to ask yourself is, and I try to think about it systematically. Firstly, is this a ruptured aneurysm? Are there any immediately worrying signs? So the ruptured aneurysm thing, you've got to ask yourself, is there any sign of it on history? Is there any sign of blood on the CT scan? And you can rule that out pretty quickly. Are there any immediately worrying signs? This could be, is this a giant aneurysm? Have they reported some thrombosis? And do they need any dedicated vascular imaging? And this can be done via an MRA or a CTA. Most commonly, people tend to find these on the MRI scan because we do MRIs more readily these days. I tend to get patients a CTA scans when they come and see me, because although it is some more radiation, it gives better delineation of the aneurysm than a time-of-flight MRA, just because of the underlying physics behind it. So, what are the higher risk considerations when you think about these? Have they had a previous subarachnoid hemorrhage? What's the age of the patient? Are we talking about an 85-year-old patient in a nursing home, or are we talking about a young patient? Do they have a family history of aneurysms? And by that, we generally consider two immediate family members that have aneurysms. Larger size, and by that, I would start. I'm a little bit more worried about aneurysms that are sort of bigger than 5 to 7 millimeters. Then the location of the aneurysm, and by that we think of posterior circulation as being more higher risk, and by that I mean the vertebrobasilar system. Are they a hypertensive patient? Do they smoke? And these are all slightly higher risks for OBJA. Sorry, my voice is getting a bit dry. Some of the studies looking at populations have identified higher risk of bleeding in Finnish and Japanese descent. So just before I move to the next type of sort of presentation, I'll give you guys a quick case example of a patient that I looked after very recently.
So Jean, before you're heading to that, I just have a couple of questions here, so it's probably
Sure.
timely too. Is it hereditary, and how should relatives be screened?
Sure. So certainly there are cases of familial aneurysms. They have not, when we say genetic association, it's not a strong genetic association like an NF2 or NF1, where where it's an autosomal dominant condition and you're just going to pass it on. It's not like that. We know that there are families that have significant aneurysms. We would offer screening if two or more patients in a family had aneurysms. So for example, this patient that I'm going to show you, they've had an aneurysm and an aneurysm that's bled. I would not screen their family for aneurysms. But if their grown-up daughter was found to have an aneurysm or had a ruptured aneurysm, I would scan all of their family members with an MRA. To that screening. So that's how I would manage these cases.
Okay. Headaches are common complaints in patients in general practice. How do you exclude a cerebral aneurysm?
Sure. So most cerebral aneurysms themselves will be asymptomatic. There is some theory that some of the skull base, and we'll see that in my case example as well, that some of the aneurysms close to the skull base, if they're irritating the dura, may cause headaches. Generally speaking, unless it is a big aneurysm that's got mass effect, it should not be the cause of your headaches. And in 99% of cases, I will tell patients who have been found with an aneurysm, who've been found with an aneurysm, who've had non-specific headaches, that the aneurysm is not the cause of your headache.
Okay. Why are vertebrae basals at aneurysms more dangerous?
So we don't specifically know the reason for that. The studies that risk has come from our studies where we retrospectively looked and also prospectively followed patients with all sorts of various aneurysms and found that for some reason, aneurysms situated in the vertebrobasilar system tend to have a higher risk of rupture. No one has done, to my knowledge, has done studies, cutting out those aneurysms, looking at them histologically. Are they histologically different? Are the hemodynamics different in the vertebrobasilar and the anterior circulation to let there be a difference? These are questions that we do not have answers for, but we know that they are higher risk.
Okay. Should you do an abdominal ultrasound to rule out aortic aneurysm?
So we know that if you have and I'll mention this a little bit later, if you have a connective tissue disorder, things like people with Ehlers-Danlos syndrome, Marfan syndrome, any of these unusual odd things, sure, those types of people can have problems with their vasculature all around their body. But generally speaking, I would not do, for your stock standard, just incidental finding of an aneurysm, I would not do an abdominal ultrasound to look for a AAA.
Okay, great. Just one more question and then you can go on to your case study.
Sure.
Advice re female who wants to fall pregnant with an unruptured AVM.
With an unruptured AVM?
Unruptured AVM.
Yeah, so an AVM is slightly different to an aneurysm. So that depends on the features. So that becomes a very specialist topic. So when I would have to see, has the AVM bled previously, the size of it, where it is there any high risk features of the AVM rupturing? Is there a feasible option to try and treat it before she falls pregnant? So there are various questions to answer. Generally speaking, if an AVM patient does fall pregnant, if I found an AVM in a pregnant woman, I would advise them to just pursue a normal pregnancy and a normal vaginal delivery and aim to treat it once she has given birth. It becomes a complicated issue if she has a bleed while she's pregnant, et cetera, et cetera. But that's a very subspecialized conversation, and I can't give any specifics on it unless I know more about the patient, more about the AVM and the individual circumstances.
Sure, thanks. You can move on to the case studies now.
Sure, okay. Thanks for these questions, everybody. So I looked after this patient, 65-year-old lady who's previously completely healthy, and she was down in the South Coast, looking for a retirement place. I forgot where she told me, Bateman's Bay or something like that. And then she started getting double vision. And over the course of the week, this double vision got pretty bad in the ophthalmology clinic. And she basically had an examination that looked like this. This isn't the patient, and this is the ptosis was in the right eye. Can anyone have a guess, Sandra, of pick this problem? Can anyone pick a lesion on this?
I'll just see if anyone who can type the fastest. I'll see if there's any questions or any responses to your answer come through. They're all being very shy, Jean.
Yep.
Yeah, they can't type that quick, one or the other. No, just crack on. No one was game enough to respond.
Sure.
There you go. Ocular motor nerve palsy.
Yeah, perfect. Who was that?
That was Peter Stevens. He's such a lad, isn't he?
Oh, Dr. Stevens. This is a classic example of a third nerve palsy. The pupil is down and out. There's ptosis. And you can see, sorry, the eyeball is down and out. There's ptosis. And you can also see, interestingly, that the pupil is dilated. And the pupil is dilated for this patient. What that tells me is that this is a compressive lesion. So the parasympathetic fibers, which control the sphincter muscle, which constricts the pupil, is located on the outside of the nerve. So if you get a compressive lesion on the third nerve, that tends to give you pupillary involvement. But if you have an ischemic cause, for example, that affects the inside of it, it tends to spare the pupil. So this to me looks like a third nerve palsy. So it's a painless new onset of a third nerve palsy. So they picked it up. They picked the third nerve palsy in the ophthalmology clinic. Good on them. But then about a few days after that, she had this sudden onset of severe headache associated with vomiting. So she actually had a subarachnoid hemorrhage. And this is what we saw on the CTA. So this is the CT scan, and this is her CT scan. And this shows a subarachnoid hemorrhage, early hydrocephalus. And you can see this is thick clotted blood on the right side. So as soon as I saw this, I thought, oh, I think I can probably localize it to the right side. So this is either going to be a PCOM aneurysm or an MCA aneurysm, but the third nerve palsy that she had, the oculomotor palsy, is pathognomonic for a posterior communicating artery aneurysm. So what happens is the posterior communicating artery aneurysm, here is where it is. So this is the carotid artery, which comes up, and this is a segment of the posterior communicating artery, and that's the aneurysm there. Can you guys see my mouse pointer or not? Okay. Sandra, can you see that?
Yes.
Okay. So this is the internal carotid artery, and that's the segment. You know, the PCOM is very small here, but that's a posterior communicating artery. And so we call that a posterior communicating artery aneurysm. And so the similar thing over here, that's the middle cerebral artery, that's the anterior cerebral artery, internal carotid artery going down, and that is the aneurysm there. And what happens is that this is just a diagram. The posterior communicating artery can cause compression on the oculomotor nerve. So the thought behind this is that in the week beforehand, for some reason, the hemodynamics, the blood flow inside this, something changed in this aneurysm and it started growing. And as it did so, it caused compression on the third nerve, on the oculomotor nerve, which is why it gave the patient a third nerve palsy. And so this is a classic example of a symptomatic aneurysm that needs to be picked up. So the posterior communicating artery causing a third nerve palsy, this to me needs emergency attention, and it's managed like a ruptured aneurysm, because the idea is that if it is rapidly growing like that, then the hemodynamics are changing in it and this will explode. Okay. When you look at these under the microscope, the way that it looks, the normal arteries look like a tube, almost look like a rubber tube. What the aneurysm looks like is kind of like a balloon when you fill it up with water under the tap, and imagine the balloon expanding and expanding, and the rubber gets thinner and thinner, and you see the blood that's swirling around, so see the water swirling around inside the balloon. That's exactly what these aneurysms look like. So the walls are extremely thin. And so the idea, if they get rapidly bigger, then it's going to rupture. So these are the ones that if you've got a painless, saw a patient with a painless third nerve palsy and they've got an aneurysm, you need to send that into the emergency room straight away, even if they've got no headache. The other types of things that could be, and these are ones that you're really unlikely to see, would be something like a giant middle cerebral artery aneurysm, which cause localized mass effect, headaches which won't go away, vomiting, weakness. Some of these giant aneurysms have thrombosis in them, have the flow. Think of atrial fibrillation, where the heart is not pumping properly. It causes, and it's not smooth hemodynamics, so a clot forms, and that you can get in a large middle cerebral artery aneurysm, and those can embolize and give little strokes and TIAs and things like that. So a giant MCA aneurysm could do that. What else could do it? Think about a very large dolichoectatic posterior circulation aneurysm. So something like this, you would get gait disturbance from myelopathy, brainstem compression, lower cranial nerve palsy, swallowing difficulty, hoarse voice, and hydrocephalus. Any of these symptoms are the kinds of things that you would scan. And if they've got an aneurysm like that, you would send that straight to the emergency room. But these are these are quite rare. So out of these, truly symptomatic aneurysms, I think the most likely aneurysm that you would see is probably the PCOM one, and even that's quite rare. And so overall, the most common thing that you will see is the incidental aneurysm. So do we have any
One
more?
of the GPs wants to know what the outcome was for the lady.
Oh, yes. So this lady, I saw this lady and she had GCS 15, was a little bit drowsy, and she had presented to the San Hospital. I transferred her immediately to Westmead Private in the middle of the night. I saw her in the morning. I discussed with my interventional radiology colleagues about what the safest, durable, best treatment for this would be. And I felt that because the aneurysm is compressing on the oculomotor nerve, I felt that the best chance to improve the functioning would be a clip. So if you pack coils into, you can see my laser pointer. If you pack coils into this aneurysm sac, the compression on the oculomotor nerve doesn't go away. Now, some patients still do get better after coiling of these aneurysms. And that's thought to be because, well, at least you get rid of the pulsation, the arterial pulsation on the nerve. But the literature would say that if you clip it and deflate the aneurysm, that the oculomotor nerve would get better. So I did a pterional craniotomy, a no-shave pterional craniotomy. I went in, I found the internal carotid artery, I found the aneurysm, I put a clip on there, then I punctured that aneurysm sac with a needle and I totally deflated it. I didn't actually go trying to peel that aneurysm wall off the nerve because I didn't want to damage the nerve. And as soon as the patient woke up, her third nerve palsy was already starting to get better. By about 1 week post-op, it had almost completely resolved. I recently saw her 6 weeks post-op, and she is absolutely perfect. And she is back to driving, playing golf, and totally recovered. So she did very, very well following surgery. So I'll just move on. So in terms of, just as a little summary for presentations to the GP, so the vast majority will be incidental, as I mentioned. It's very important to rule out the red flags like we talked about. And this is quite important, reassuring patients. Most of these will not grow or rupture or need treatment. However, they may require some observation and ongoing follow-up. This is very, very important. Vascular imaging, of course, is important, especially if it's been found not just non-contrast CT, and MRA or CTA, both are fine. If I see them and they've only had an MRA, I will usually do a CTA at least once to take a good look at the aneurysm, and then I'm happy to do an MRA scan for follow-up to avoid the radiation. So I wanted to move on to just explaining briefly, as a cerebrovascular surgeon, my perspective when you send me a patient. So when I see a patient with an aneurysm, I try to think of it as patient factors and aneurysm factors before I weigh up the pros and cons and give my advice and talk a patient through this illness. So in terms of patient factors, like I mentioned, I think about the patient's age, because remember, we're talking about cumulative risk over the course of their lifetime. So the percentage risk that a 77-year-old patient carries is very different to what a 25-year-old patient has to carry for the rest of their life, the cumulative, not just the 5-year or the 1-year risk of rupture. And that's all, that's all very obvious. Have they had a previous rupture or subarachnoid hemorrhage? Do they have a family history? What's their ethnic background? What would be their fitness for treatment? Am I talking about somebody who's got advanced Parkinson's disease, who's got dementia, or who's got major ischemic heart disease and other problems where we say, look, you're probably not fit for clipping or anything like that? Do they have a connective tissue disorder? And then the kind of things that are reversible patient factors. Are you a smoker? Do they have hypertension? And then I look at a number of aneurysm factors to consider. What's the location? Is this anterior or posterior circulation? And what's the position along the internal carotid artery? And by this, I talk about a paroxysmal control. And I'll talk you guys through a little bit about what I do when I clip an aneurysm in a little while. How big is the size? What's the morphology? Is there a worrying daughter sac? Does it look very irregular? Multiplicity, are there multiple aneurysms? What's the neck like of the aneurysm? Is it wide or narrow necked? What's the proximity of this aneurysm neck to important vessels and perforators? By perforators, I mean the tiny little vessels along the internal carotid artery or the middle cerebral artery that perforate the internal capsule, the basal ganglia, and damage to any of these vessels will end up in usually with a terrible outcome. So, you know, when we say, should we treat these aneurysms? The question I ask myself is, what is the natural history or the risk of rupture of this aneurysm based on the best literature and the data that I have available? And what are the available methods to treat these aneurysms, whether they be open, endovascular, or combined? And what is the risk profile or the pros and cons of each? And the open and endovascular are two very different procedures. And the quick note I'll say is that their risk profiles are very different. And it's very important when I counsel a patient that yes, coiling through the leg is minimal access in the sense that it's essentially a puncture wound in the leg. But minimal access does not mean minimal risk. So when you are manipulating something from the leg, you know, a catheter, a fairly rigid catheter from the leg by twisting and pulling all the way up to the brain in an aneurysm. Remember I told you what an aneurysm looks like, how it's like a balloon full of water that's swirling under high pressure, and you've got a plastic tube inside there with wires and fiddling around, and the control that you have with that. Yes, it's minimal access, but the risk profile is there. These patients that have endovascular treatment that might need a complex stent arrangement may need to be on significant blood thinning treatment. And, you know, of course, when you put somebody on, dual antiplatelet therapy or prasugrel or any of the new really strong anticoagulants that have no known withdrawal reversal for it, then certainly that carries with it a different risk profile to open surgery. And so we have to, I will chat with my endovascular colleagues in a very open and frank way about what we think is the most effective, as in the most durable treatment, meaning that there are some cases where if you just put coils into it in a young patient, there's a chance that the aneurysm will come back. And you can imagine that if you treat things multiply through stents and coils and things, and it keeps coming back, then you say, there's nothing else available through the leg, you have to clip it. That is a very high risk operation. And so durability is important. Of course, the safety profile is important as well. So this is what I think. And then I talk to patients about the balancing of this risk, meaning that we have to balance the natural history, the risk of rupture, and the anxiety that comes with having a knowing about an aneurysm versus the risks with treatment. So essentially, I'm asking a patient, if I treat somebody, in most cases, I'm asking them to, a totally asymptomatic or neurologically normal patient, to take an upfront risk with treatment to avoid the natural history. Okay, so this is one of those, you know, very interesting but difficult situations where you can have, and I say to a patient, you can walk into the operating room essentially totally asymptomatic and neurologically normal and come out totally not that way. You know, and that's counted by your cumulative risk of rupture over your lifetime. So it's an important conversation that I have to have with patients about balancing this risk. How can I modify this risk? Well, the outcomes of these patients improve if firstly, we have better detection, close monitoring, and we can control the patient factors such as hypertension and smoking. There is a heap of literature being done, some of it using machine learning and artificial intelligence. The computers and the machine learning will be able to analyze CT scans and CTAs and MRIs of patients with aneurysms that rupture and don't rupture. And we feed hundreds and thousands of this data into the computer, and they will be able to pick up subtle changes and causes for what aneurysms rupture and what don't. So there's a lot of research going into it with big data about how we can pick up patients at a population level, about who needs to be screened and which ones are the higher risk aneurysms. The outcomes will also improve with improved treatment outcomes. So if I do better, precise microsurgery, so if this surgery is being done by somebody who has an interest in it, who's good at microsurgery, who's gentle with the brain, we do good patient selection, and we have a good multidisciplinary and robust discussion with our interventional radiology colleagues about the most durable and safest and effective treatment, then the patients will have better outcomes. So I'll show you another case study that I looked after very recently. This is a 56.
I just have a couple of questions, Jung.
Yes.
I might squeeze those in before you go on to the case study. After treating a ruptured aneurysm in a younger patient, would you prefer an MRI or a CTA as long-term follow-up?
It depends on what we have done to treat the aneurysm. So a patient who's had a ruptured aneurysm who's been treated should be seeing somebody for the rest of their lives. I would treat, if they've had a clip, then I would follow them with a CT angiogram, just because there's not as much clip artifact with it. If they've had coiling, it causes a lot of artifact on the CT scan. So we usually follow with MRI scans. Depending on how we have treated it, the location of it, if it's a complex reconstruction and it's hard to visualize with CT or MRI, we may even end up doing another diagnostic cerebral angiogram through the leg to take a better look.
Okay, and just another question. For small aneurysms lead to vascular disease and dementia as you get older?
No, small aneurysms do not lead to vascular dementia.
Okay, and I have a strange one here, and I hope you understand it because I don't. It says surgically treated circle of Willis.
Yeah, circle of Willis is where the most common aneurysms are, is where they mostly arise from, and we, certainly can treat those surgically. But, with all the patients that I come through, I will, go through the thought process and discussion with my INR colleagues, so that we, a patient, anyone that gets treated through our practice in a Westmead Public Hospital will have had a number of specialists involved in their care indirectly to make sure the patient is having the most evidence-based and safest, durable, effective treatment.
Great, thanks, Sean. You'd like to move, I think you're onto a case study next, won't you?
Sure.
Yep.
So for this case study, I saw this Korean lady very recently. She's 56, she's non-smoking, totally well lady, has a history of migraines. And in the month of December 2020, had worsening headache, blood pressure was elevated to 160 systolic. And this is not her normal blood pressure. And then the headache somewhat responded to a trial of antihypertensives. She has a family history of aneurysms. The mum died of an aneurysm and the brother had an operation for an aneurysm repair. And she had had an MRI scan performed in November, and they reported a 2 millimeter right ICA aneurysm. The CTA performed in December. They reported on the CTA a 4 millimeter right ICA aneurysm. And this patient was offered surgical clipping in a different institution, based on family history, symptomatic, and growing aneurysm. So this patient came to me, and the questions that came through my mind were, number one, is this a symptomatic aneurysm? Is a 4 millimeter aneurysm going to be symptomatic? Now, this lady had some improvement with antihypertensive. So one option was that, look, she had raised blood pressure and that was the cause of her headaches as worsening from her baseline. The other thought is this internal carotid artery aneurysm. Could it be contacting the dura? Now, the brain itself doesn't have pain fibers, but the dura mater does. So maybe if it's irritating the dura, could this be it? She had retroorbital headaches, so potentially. What are the factors to treat? The fact that she has a family history, a question of whether it's symptomatic. What are the factors to not treat? Would be it's an internal carotid artery aneurysm, and the ICA aneurysms are lower risk aneurysms. It's not a big aneurysm. It's only 4 millimeters. The fact that that growth between MRI and CTA, there can be some discrepancy just because the technology and the physics behind the scans are totally different. And if so, what is the best option to treat? Is it clipping? Is it endovascular? And so I wanted to get her a diagnostic angiogram through the leg to take a better look at the aneurysm. And this is what we found. Let me just try and play this. So, okay, I'll take a little poll now. I'll play it again. My question to you all is, how many aneurysms do you see?
Sure, that's a bit hard, isn't it? Okay, we'll
Okay,
wait.
this is hard.
Who's quick on the keyboard? Let's see.
Okay. You can have a guess.
Me, the most unclinical person.
Andrew, you can have a guess.
Four. There you go. Two have come in with 4.
Okay, there.
4,
Okay.
3, 2. There you go. Take a picture.
Okay, sorry, I can't see everybody's answers. I'll just move on. So this is the, let me get my laser pointer back. So that's the internal carotid artery. And we've got an aneurysm here. And then we've actually also got another aneurysm here. So this patient was found to have 2 aneurysms in the right carotid artery. And she was actually also found to have another small aneurysm on the left side as well. Okay, so just moving on. So based on the angiogram findings and my discussion with my colleagues, so we planned for an endovascular flow diverting stent. And I'll go back and I'll show you why. So when I clip an aneurysm, so think of the direction that the blood comes through. It comes through like this, winds across like this, and it gives you very high pressure like this. Let me try and draw. So let's say, for example, that, can everybody see this? Let's say there's an aneurysm there, okay? So when I try to clip this, the most important thing in aneurysm surgery is proximal control, meaning that if I play with this thing and it ruptures, the whole screen and the whole head will fill with blood really quickly. And the brain is not like doing leg or abdominal surgery where if there's catastrophic bleeding, you can just keep packing with sponges. You can't do that to the brain. So to get control, I need to put a clip, a temporary clip like that, in order to stop the bleeding and so the patient doesn't die on the table, and then dissect around the neck and then put a little clip there like that. Okay, I hope that makes sense to people. Okay, now what happens is that, think of the carotid artery in the neck. So in the neck, you can feel the carotid pulse in your neck. At some point in time, that carotid pulse, the carotid, will become intracranial. And so what it does is it goes through the skull base. So it goes through the bone and then goes through the cavernous sinus. And then at about this point where the ophthalmic artery comes off, that's the ophthalmic artery, it becomes subarachnoid. And this area is like over-roofed by bone like this. And so it's very, very difficult to get proximal control because that's embedded in bone and that's inside the cavernous sinus, which is full of veins. So in cases like this, we have to drill this bone off as a starting point just to even see this area. With the fine little drill, imagine drilling around that aneurysm, which is very doable, but it's tricky. And in some cases, we have to prep the neck and we might have to open the neck and put a temporary clip on here to stop the bleeding if it all turns pear-shaped. And my take on this was that because it's got another little aneurysm there, the whole carotid is actually a disease segment, and that this could be treated really nicely with, sorry, I've turned this into a dog's breakfast. And my feeling was that this could be treated really nicely with a flow diverting stent, which would span the carotid like that. And this would cover the neck of the aneurysm. And it would also treat the cavernous aneurysm. Mind you, let me just show you the other aneurysm. Okay, this other aneurysm here is not in the subarachnoid space, meaning that's in the cavernous sinus. So that's not in the subarachnoid space. So if this aneurysm bleeds, it will not give you a subarachnoid hemorrhage. That will give you a carotid cavernous fistula with proptosis and stuff like that. So it wouldn't give you a subarachnoid hemorrhage. Anyway, so I looked at this scan in detail with my endovascular colleague, and we felt that the best thing to do would be to give her a flow diverting stent based on the risk profile, and based on a multitude of factors. So that's what she is having.
Was there any danger of stroke when you clip the carotids?
So you can clip, so remember that the circle of Willis means that blood comes from the other side to, that blood comes from the other side, goes through the anterior communicating artery, posterior communicating artery, in order to perfuse things. So you can have a clip on the internal carotid artery for a long time. In the case of something like, if I put a clip on the middle cerebral artery, there's no collateral circulation from the other side. And so really I would only clip the middle cerebral artery or a distal vessel for 5 minutes at a time. So you can imagine in a ruptured aneurysm, it's a very stressful situation, because if it pops early after I haven't done much work, you've got to put a clip on, and then you've got about 5 minutes or so to try and get control of it. And then you can, but sometimes what we will do is we will get some control, release it, let it perfuse, and then re-clip again. And while we're doing so, we give deep sedation to the patient. We give induced burst suppression, so the brain's oxygen requirement is not as much. And so that lessens the risk of having a stroke or anything like that. So what I'm telling you about this temporary clipping is a very standardized technique in aneurysm surgery. It's very safe.
Okay. Another question, she also had an aneurysm on the other side.
Yep.
Is it risky?
Yes. So that other one, we are planning to watch that carefully, because that is only 2 millimeters. So, based on multiple aneurysms, this one is kind of bilobed. She's got headaches on the right side. She's very anxious about it. So we thought that the best thing would probably be to treat it if we had a viable option. The options are surgery and endovascular. I felt that in conjunction with my endovascular colleague, that the flow diverting stent, although it has a risk of about a 3 to 5% risk of a stroke, and the fact that she needs to be on blood thinning medication, I thought that had a more favorable risk profile than me doing a clip, which is why I told her, I think you need a flow diverting stent. And so she's getting that done in the next 2 weeks. So I thought here I'd kind of pause it here and take a couple more questions or comments from anyone. Sorry, I've been talking for all this time. Sorry if it's been a bit boring for everybody.
No, it's been interesting. Thank you, John.
Thank you.
There was one earlier, but I think you covered it, but you may just like to go over it again. And it was specific signs for diagnosis.
Specific signs for diagnosis?
Yes.
I would say most aneurysms are asymptomatic and incidentally found. The specific signs and symptoms, sudden onset, like we talked about earlier, sudden onset, severe thunderclap headache. They will say that it feels like a train has hit me. It's the worst headache of my life. Comes on suddenly. It will wake you up from sleep. They will drop everything. They will remember the specific moment it came on and what they were doing, often associated with exertional activity, although not always. And these things can be like during sexual activity, being in the toilet, or having a heated argument with somebody, but it can happen at any random time. Okay, it can also be associated with vomiting, and so and then the other ones, the symptomatic aneurysms, would be the painless third nerve palsy with the dilated pupil, associated with an aneurysm. That's an emergency that needs to come straight in, and some of the rarer ones that we went through. What I will say is probably the most important thing I think of being a cerebrovascular surgeon is this diagram, and being able to make sure that we carry patients, give them a clear understanding of what we are trying to do, the risk they are going to take, because there's a risk both ways. There's a risk with natural history, there's a risk with treatment. So making sure that patients clearly understand this and that they are very comfortable with this, alongside being able to give a very good definitive treatment option, I think is the most important part of being a cerebrovascular surgeon, is what I'll say. And I'll show you my last slide. Are there any more questions, or I'll go on to my last slide?
More questions. Just pop the QR code up if they've got one.
So a little bit about me, just at the end. I work with a guy called Dr. Mark Dexter. I'm sure you guys all know Mark. We've sort of created a partnership called Westmead Brain Surgery. Mark Dexter's an exceptional, nationally recognized surgeon, as you know, and Mark has been a long-term mentor and a teacher to me, and I have Mark went to fellowship in Dallas, and I've been in the same fellowship as Mark Dexter. So we are cut from the same cloth, and so we think about patients, very, very similarly. And so these are my details. I'm really happy to, looking forward to working with you. I've got my mobile number up there. Please feel free to just call me or text me if you have a question. I already have a number of GPs that I do that with. Any question that you have, a scan you want me to take a look at, please think of me as a colleague and a partner, and I look forward to working with you soon.
Thanks, Jung. Now, you can't get away that quickly because there's a couple more questions. Do multiple aneurysms, as in this lady, is there a suspicion of collagen disorder?
No. Generally, if you have a collagen disorder, you will know about it. Like, they are very syndromic, whether that be a Marfan's or something like that. The multiple aneurysms is more commonly seen in familial aneurysms. For some reason, they have multiple, and for some reason, they bleed more often. Why that's the case? Are they histologically on an aneurysm wall? Is the pathophysiology different? We don't know. Is it the fact that they have more of them, which is why they have an increased risk? We don't know the precise answers to that.
Okay, another question. From a previously coiled anterior caudal artery aneurysm, where the coils have packed in and the neck has widened, when would this have to be clipped?
So it depends. I would want to look at the progression of the size of the neck. I would want to know whether the aneurysm has bled before. If it has bled before, I would say to the patient, I think it needs to be treated. And if that's the case, if I saw a patient and I would say, you've had a previous aneurysm that's ruptured, you've had it coiled, and the neck is coming back, my thoughts are, and depending on the age of the patient, and of course, fitness for surgery, but presuming that we're saying it's a fit patient that should have it treated, I would say, one, I think it needs to be treated because I believe that the natural history is worse than the risks with surgery. I would say so. And if it's previously coiled and packed off, so the problem is that with that, because the anterior choroidal artery comes right off the base of it, if you stick more coils into that, it can block off the anterior choroidal artery and give somebody a stroke. And those sorts of things are the downsides with endovascular treatment. And so I would speak to my other colleagues. I would say, do you have a simple solution to this? And I gather that they're going to say no, that they would have to do something really fancy or sacrifice the artery, which is not good. I would not sacrifice an anterior coronal artery. And so I would say that you should clip it, and I would do that in the next, say, 2 or 3 weeks' time.
Okay. Jung, thank you for your time. I know that you've had a very busy day today and you have a small or a young family to go home. Jung just became a dad for the fourth or third
Fourth
time?
time.
Fourth time.
Yes.
And he experienced our hospital from the other side as his wife gave birth in our hospital. And
that's right, yes.
So he was fully experiencing what we were like before he started working with us.
Oh, yes, absolutely. Yes.
So how old's your baby? What's the youngest? How old is?
Oh, 9 weeks now.
9 weeks, yeah. So he has sleepless nights and busy
That's right.
days.
That's right. 4 is too much, by the way. No more.
Well, I would, yeah, there's a lot. Oh, well. Can't go back now, Jung. There's no turning back from
That's right. That's right.
Guys, Jung's around if you have any questions or you need to just chat to him about any patients that you have. He does have rooms on site. As you can see, he's a pretty easygoing, approachable guy. So don't hesitate to get in contact with him if you need any assistance going forward. Thanks for your time, everybody. Enjoy your evening.
Thanks, everyone. Have a good night.
Take care, everybody, and we'll catch up soon. Thanks, Jung. We hope you have enjoyed this GP education session. If you wish to gain CPD points, this activity is now a quick log activity, which means you need to head to the Royal Australian College of General Practitioners website to log your own points. We hope you can join us for more of our GP education in the coming weeks. Thank you.